So it's really a great pleasure to be talking today. There's so many of you. I'm slightly intimidated to have a room with so many people with an interest in microbes in there. And as a hemato-oncologist, we all have interest in microbes because we actually spend most of our time looking after infection once we've made a diagnosis and started our patients on treatment. So I don't quite agree with Professor Sefton. Maybe we like to spend a lot of money, but we do have an interest in the area, and we could be a little bit more judicious. This was supposed to be my second slide, not my first slide. And why am I showing you a slide of a meeting that's happened already? Was because some of the questions I'm going to ask you were also raised at this meeting, and it'd be very interesting to compare responses. This is where I work. So Gemma, as you've seen, works at Public Health England. I spend most of my time in Barts Health, but at St Bartholomew's Hospital. And as you can see there's some aspects of a new hospital which are rather surprising, and that is, it's a rather splendid building. And along with it being the oldest hospital in Europe, founded in 1123, it's also the newest hospital in Europe. And I'm not always a fan of management. I don't know how many managers are out there. But they got some aspects of this building correct, and it's worth popping in because it's a rather splendid new hospital we have. So this is a question I'd like you to consider. Now, I suspect most of you in some capacity have a role of antifungal management of patients in your institution or samples you get in your laboratories. And if you don't, it doesn't matter. Consider if you did have, what would you think might be the answer to this question? What's the biggest challenge you have in antifungal management? We're not going to have a show of hands, I don't think. But I can tell you what, we had keypad voting at the meeting I just mentioned. I can tell you what the audience of that meeting said. And in fact, there was a pretty equal distribution around the various options there. So a lack of biomarkers. TDM refers to therapeutic drug monitoring if you're using antifungal drugs such as itraconazole, voriconazole, or posaconazole. Diagnostic tests not being available rapidly enough. Guidelines and stewardship is an interesting one, whether you think that would make a difference to your practice. But also quite a few people thought they didn't actually have data on what was going on in their own unit or centre as being a major issue. And then following from that comes the question, well, what would help you most? Would you like access to these tests, therapeutic drug monitoring, etc.? And I was a bit surprised at the response to this question because over half of the audience said it was number 5, which was very gratifying for me because I'm going to spend a bit of time in this talk talking about database and collecting data in what is a very difficult area of practical management. And I'm going to do that by describing to you what we've done in the last 15 years or so in the hemato-oncology unit at Barts Hospital, and finish with an area which will be very familiar to all of you in the room, so stewardship. But stewardship really refers to antibiotic stewardship in most institutions and how we can support that activity in the antifungal area with diagnostic tests and a useful database. It is important to talk about terminology to make sure we are actually all using the same language. And Gemma has already covered some of this terminology, but I will still reiterate it. Empirical therapy in this setting refers to the fact we are not performing any tests and we are managing the patient's signs and symptoms, and on the basis of that we begin an antifungal drug. Screening assumes you have some tests to use, but if you have tests to use, then in the screening strategy you can use some of the biomarkers that Gemma mentioned, although she didn't mention beta-D-glucan, in a twice-weekly strategy. That's the commonest way it's used in inpatients perceived at being high risk of invasive fungal disease. Now, a screening strategy is only meaningful if the tests become positive before your clinical triggers. And it's not always clear to me that that is the case. Or we can use a diagnostic-driven approach. Now, that is really an empirical strategy, except you don't start the antifungal drug. You perform the tests that you have available to you, which will include the biomarkers shown there. So these biomarkers, if you have them, but routinely imaging, and that's primarily a CT scan of the chest in our setting, and perhaps even bronchoscopy to obtain BAL fluid. But what we don't get is culture and histology. That really is very rare in this patient setting, and also in a number of other settings of the immunocompromised host. So Gemma's already presented these factors. I don't need to go through them again, but these are the factors we actually have to hand in clinical practice. And so we're left with this. On a routine basis, we are looking at a patient who we think may have invasive fungal disease, but it's not always that obvious. So what do? Either we use tests if we have them, we don't use tests even though they're available, but more often than not, we start treatment. And that means we do not identify an organism. Now, many of my colleagues seem to think that performing this test and finding an abnormality on the CT scan tells you you're dealing with invasive aspergillosis. But I don't think I need to tell this audience that it doesn't. It just means you have a pneumonic process, probably a pneumonic process of some nature going on, and we don't even know it's a fungus. So if we don't make any attempt to identify an organism, we will continue in the way we've carried on for a number of years. And this is really what we were doing at Bart's pre-2008, an approach which I would describe as empirical. This is a schematic of it. Patients who are at high risk, or we perceive as being at high risk of invasive fungal disease, are given a prophylactic antifungal drug. I'm not here to talk about the choice of drug today. And patients who fit the typical picture of being neutropenic, septic, despite broad-spectrum antibiotics, at a certain point in time, we will start to consider, is there something else going on? And in our centre, it has been 72 hours of persistent fever for many years. And we perform a test, which is imaging, and we do or we do not start antifungal drugs at that point in time. The result of the CT scan should guide what we do. So if the scan is negative, we do not consider treatment, and if the scan is positive, then we pursue antifungal therapy. Now, with that approach, we found we were treating 2/3 of our acute leukemic patients and allogeneic transplant patients with systemic antifungal drugs. And with that, there was a very significant year-on-year rise in our antifungal drug budget. So we decided we could do better. We introduced a screening strategy, as I'll show you here. And we use galactomannan. Why do we use galactomannan? It is the most widely used commercial assay in the world for trying to detect aspergillus. In fact, at that point in time, there really wasn't anything else available commercially, and we used it twice weekly. But over a period of 3 years, in our centre, it made absolutely no difference to our management, and we did not start a single patient during those 3 years on antifungal treatment because of the galactomannan assay. So we stopped it. And we decided we were spending too much money on a test which wasn't altering our practice, and we went to what I would now call a diagnostic-driven strategy, but without any screening. So you can see it's changed a little bit. The font has got a bit smaller inside the boxes because there's more detail in there, but it doesn't matter what the detail is. We were a little bit more careful about who is actually at risk and what antifungal prophylaxis they should get, if any. But the principle of management hadn't changed. Neutropenic, persistent fever despite broad-spectrum antibiotics, then we performed some investigations, the CT scan, and now we were using galactomannan. So it's a clinically triggered diagnostic response. And the team are supposed to wait for the results of these investigations before starting antifungal drugs. Whether or not an antifungal drug is started depends on the range of options of the CT scan and the galactomannan, but I'm not going to go into the detail of that. So what did we find with the introduction of that approach in 2012? Well, in the NHS, we're very good at, pharmacy is very good at keeping an eye on our drug budget. we're not so good in the NHS at talking about activity and cost. So I can only show you drug budget costs. So this is the annual antifungal drug spent in the hemato-oncology unit at Barts, and you can see over the 12 years from 2000 to 2012, there's a general but very marked trend upwards. And in the last financial year shown there, we spent £1.2 million. And this is not very different in any other major haematological transplant centre in the country, or in the world for that matter, although there are variations. So we introduced our strategy in that year 2012, and last year there was a very significant decline in the antifungal spend to £700,000. And that's in the context of our actual workload, our activity, increasing very significantly during that period of time. So it may be a genuine change due to our introduction of the strategy. It may not be. I think time will tell. But I think it looks positive. Now, in terms of outcome, it's very hard to assess outcome in an area where you can't make a diagnosis. That's really quite a challenge. But we're not aware of any change in deaths attributable to invasive fungal disease over that period. So we could be happy with ourselves and say, we'll stop there. We're doing okay compared to a number of other centres in the UK. But we actually want to take what Gemma's presented to you, the 3 assays she's mentioned, the Triad X service, and introduce that into our clinical practice. And we will use these assays at the same time points we were previously using the galactomannan test in blood and also in BAL fluid. Now, as a personal preference, it may not be the preference of the patients, BAL fluid is a much better tissue for making a diagnosis of aspergillus, as aspergillus is obviously an airways disease, and about 80% of aspergillus infections in our patient population are in the lung. So that's the logic of this approach. Clearly it doesn't pick up all mold infections, but we are at least making an attempt to diagnose what is epidemiologically by far and away the commonest problem we think we're dealing with. And having the assays is one thing, actually implementing them and following them is something else. And for that, I do think antifungal stewardship is the way forward. There are a number of centres in the UK that have introduced active antifungal stewardship teams, and we are going to go in the same direction. And this work is done with Gemma and also Dr. Manuel in PHE and myself. This is in hemato-oncology, but I really think it does apply to all areas of the trust where this is relevant. So I'm not going to talk to you about antimicrobial stewardship, but just to point out that antifungal stewardship is a specialised area within that, because this is not about drug resistance. We are not concerned here about the development of highly resistant fungi, although that may be coming, but that's another talk by people who know more about it than I do. This is not just about cost either. This is about best care for patients, because we know we are treating many more patients with these drugs than actually have invasive fungal disease. The challenge we have is actually knowing who not to treat. And for those reasons, it's not a job for an individual checking a drug on a drug chart and the dosing and is it being used for the right length of time. This includes a lot of clinical input. And this requires buy-in from those units where an antifungal stewardship team may be employed. Gemma's talked about the assays, so I won't say anything about the assays. But you can't do this sort of task and not have data to show the impact of what you're doing. And the fungal audit tool is a web-based system that we developed a few years ago, and with the rise of the interest in stewardship, has just been modified at this point in time actually to be a more user-friendly tool for stewardship purposes. It was always designed, despite its name, to give a complete microbial picture of what is going on in any given unit, or depending on how you wish to use it, across an institution like a whole trust. And I'm going to attempt to show you if this will work. But all online right now. Now this arrived last week in my inbox from the company that has made it, called Cicid Limited. So we're just in the process of actually proofing it to see that it will actually do what we hope it will do. So at least it tells me my password's about to expire. Well, that's a good thing. So this is the home page. And on this page, you'll get a variety of data around the status of the information in there. I'm not going to dwell on that. This individual hasn't had their baseline data completed, so you'd go into the system and complete it. And this individual I put in this morning, and we're going to look at completing their information about their hospital admission. So that would include information around what episode this is, if I just move that for a second. Their weight, for example, their disease status, so I've said the patient's got relapsed disease. Another window would have collected already what is their underlying disease. Reason for admission, so as you can see here, there are a variety of choices. You have to bear in mind that I developed this and I'm a hemato-oncologist. So there's a strong bias in the fields at the moment towards hemato-oncology. But this is all in development. And although we'd like to go live with this, it's going to keep developing in the future. So let's say sepsis management. Okay. Another issue in this area is how do you decide a patient had an episode of invasive fungal disease or they didn't, in the absence of histologically or microbiologically confirmed infection? And there is only one set of criteria that we can use that's published, and that's the EORTC MSG criteria. So unsurprisingly, the tool includes all the parameters required for making that assessment, including, for example, here, is the patient on T-cell immunosuppressants? So I've chosen a patient who's had alemtuzumab or Campath, but as Gemma had mentioned, you may have had a patient with rheumatoid arthritis who's been on anti-TNF agents. What about drugs? This is one thing I put in and I rather liked. You may feel it is relevant or it's not relevant. Fever. So our practice is driven entirely by fever in reality. So it's not something you can record very easily because fever is recorded many times a day. But in this system, you can put in a daily fever. How you want to use it is up to you. But what the system will do is you put the data in, it will produce a picture for you, which will give you the patient's fever every day with the results of any tests you've performed, with the antibiotics that they have been given, and you can see pictorially over time what has happened to your patient. Now, it may or may not be clear to you, but that is incredibly helpful when you're trying to assess if any given episode was actually an episode of invasive fungal disease or not. I'm going to pass on all those admission criteria. So although this is designed to be a fungal audit tool, it will also, and it is meant to collect data on what is happening microbiologically with the patient. So are they on an antibiotic as a prophylactic drug? And if they are, you can enter that here. So this drop-down menu gives you ciprofloxacin. You can choose the dates. It doesn't actually give you a dosage, because I was more interested in fungal drugs, so you collect fungal drug dosage but not antibiotic dosage. But this is the modification. You can see here, although it's been chopped off, guideline compliant. Is the management consistent with the guidelines that you have in your unit or your centre? And a stewardship comment, which is not necessarily the same thing. Was this management, from a stewardship perspective, appropriate or inappropriate? And then there are more drop-down boxes as you go further. So I'm going to stop there, but I think you get the idea of the information that's available in this tool. And I'd be very happy if people wish to ask me questions about it or discuss it after the talk as well. So I'll just go back to, there we go, this slide. How are we doing for time? Almost there. Almost there. So what do we expect? What do we hope by introducing an enhanced diagnostic strategy? I admit focus specifically against aspergillus, but it's a start. Well, we would hope to control our drug costs at least, and perhaps we can achieve further decreased costs by better management. a key issue is, will we be harming our patients? Well, there really are quite a lot of papers that have been published now showing that a strategy which withholds empirical therapy is safe. So I don't think we should be so concerned that this isn't a safe strategy. And I would actually contend that you will achieve better outcomes. If you are not giving these potentially toxic drugs to patients who do not need them, then one would anticipate that's a good thing. It's not just about cost. And I hope if there is an uptake of the use of the fungal audit tool, then we could develop a clinical research network across several centres, because we will all be collecting the same data. So I'm going to pass on this slide because of the purposes of time, and just say that yes, diagnosing invasive aspergillosis is a challenge, but we are making progress. And thank you for your time and attention, and thank Gemma as well.